Imagine this. A patient rolls into the ER and their blood pressure is just completely off the charts. Our immediate gut instinct? Bring those numbers down to a normal range and do it fast, right? Well, actually, what if I told you that dropping that pressure too quickly could cause an ischemic stroke or even blindness? So, is rapidly lowering extreme blood pressure always safe? Counterintuitively, the answer is absolutely not.
Take a look at this quote straight from the British and Irish Hypertension Society. The phrase that really jumps out is right at the end there, iatrogenic harm. In plain English, that means harm caused by the medical treatment itself. You see, if we misjudge a severe blood pressure spike, our well-intentioned, rapid treatment might be the exact thing that hurts the patient. Getting our triage right isn't just arguing over semantics, it's quite literally a matter of life and death.
Welcome to this explainer. Today, we're taking the British and Irish Hypertension Society's highly detailed position document on managing hypertensive crises, and we're boiling it down into a clear, actionable playbook. If you're working in cardiovascular health, you already know how tricky these extreme cases can be. Having a solid, updated framework, it's an absolute game changer.
Here is our roadmap for today. We'll start with the blood pressure paradox, define the 3 distinct crises, look into the autoregulation danger, assess the patient, and finally, tailor the treatment.
Section 1. The blood pressure paradox, when lowering numbers can actually cause harm.
Section 2. Defining the 3 crises. Precision in language saves lives.
To get this right, the very first step in clearing up clinical confusion is completely ditching vague terms like hypertensive urgency. The Society points out that this term just causes unnecessary panic and doesn't actually help us figure out how to treat the patient. Instead, we need to focus on 3 distinct categories. Number 1 is acute severe hypertension. This is a massive spike, usually a blood pressure over 200 over 120. But here is the kicker. This happens without any evidence of acute or life-threatening organ damage. It's scary high for sure, but the organs are holding their own. This is our baseline crisis state.
Now contrast that with a true hypertensive emergency. This is elevated blood pressure, which, if it stays that high over just the next few hours, is going to lead to progressive, life-threatening organ damage. We are talking about immediate, critical threats. Things like acute pulmonary edema, an aortic dissection where the vessel wall is literally tearing, or acute renal failure. In this state, the clock is ticking, fast.
Then we have the third category, malignant hypertension. This is a highly dangerous, distinct pathophysiological state. The absolute hallmark here, severe damage to the tiny, fragile blood vessels in the retina. To diagnose this, you are looking for concurrent bilateral grade 3 damage, think flame hemorrhages or cotton wool spots, or grade 4, which is papilledema, meaning swelling of the optic disc. The eyes are literally giving you a front row seat to the vascular destruction happening everywhere else in the body.
And it's fascinating how these conditions interact. While malignant hypertension and hypertensive emergencies are technically distinct, they can absolutely collide. Think of it like a giant Venn diagram. If a patient with malignant hypertension suddenly develops multi-organ damage, let's say they develop hypertensive encephalopathy on top of those retinal changes, well, they've crossed over. They are now in a complicated state that has to be managed as a full-blown hypertensive emergency.
Section 3. The autoregulation danger, the body-shifted thermostat.
So you might be wondering, if a patient's blood pressure is sitting at 220 over 130, why don't we just slam it back down to normal? The answer is autoregulation. Normally, organs like your brain and kidneys perfectly regulate their own blood flow across a pretty wide range of pressures, usually a mean arterial pressure of 50 to 150. But in chronic hypertension, the body's thermostat shifts upward. The brain and kidneys actually recalibrate. They expect and frankly demand higher pressure. Their new absolute minimum for getting enough blood flow is now much higher than yours or mine.
Because of that recalibrated thermostat, the risks of dropping the blood pressure too fast are just terrifying. If you force the pressure below their new elevated thresholds, you literally starve those vital organs of blood. And we aren't talking about the patient just feeling a little dizzy here. We're talking about devastating, irreversible complications. Cortical blindness, ischemic strokes, myocardial infarctions. By trying to fix the number too quickly, we can inadvertently trigger a complete catastrophe.
Section 4. Assessing the patient. The diagnostic playbook.
To safely navigate these spikes, it all boils down to 4 critical steps. First up, the patient history. Are they actually taking their meds? Are there secondary causes, or maybe illicit drugs like cocaine in the mix? Second, proper BP measurement. You've got to check both arms and look for radiofemoral delay. That's a pulse mismatch that can be a massive red flag for an aortic tear. Third, and honestly I cannot emphasize this one enough, fundoscopy. Looking into the retina for those grade 3 or 4 changes is so vital, but it gets missed all the time in busy ERs. If you don't look in the eyes, you literally cannot diagnose malignant hypertension. And fourth, targeted labs and imaging, like a quick bedside urine dipstick or a CT scan if you suspect organ damage.
There is a triage framework that anchors everything we're talking about. The most critical pivot point in evaluating these patients boils down to one simple question: is there life-threatening organ damage or retinopathy? That single question dynamically dictates your entire game plan. If the answer is no, you're dealing with acute severe hypertension. If the answer is yes, the path splits based on whether it's just eye changes, meaning uncomplicated malignant hypertension, or a broader acute hypertensive emergency. Answering this dictates exactly how fast and with what tools you treat the patient.
Section 5. Tailoring the treatment. Fast versus slow reduction. Let's break down these two completely different approaches. For acute severe and uncomplicated malignant hypertension, your golden rule is slow reduction. Think days to weeks. You're going to rely primarily on oral medications, things like amlodipine or atenolol. You actually want to avoid IV therapy here completely, so you don't accidentally drop the pressure below that shifted autoregulation threshold we talked about. But for a true hypertensive emergency, that's when you need an ICU or a high-dependency unit. You bring out the titratable IV medications like labetalol or nicardipine to drop the mean arterial pressure, but, and this is key, usually by a maximum of just 20 to 25% within those first few hours. It is a highly controlled, partial reduction.
And if you are in that true emergency state, your target and your drug choice depend entirely on which organ is taking the hit. The pathophysiology completely dictates the pharmacology. Take an intracerebral hemorrhage. We're aiming for a systolic target of 140 to 180, usually with IV labetalol. But pivot to acute aortic syndrome, where the aorta is actively tearing, and the playbook completely changes. You have to aggressively drop that systolic pressure all the way to 120 and crush the heart rate below 60 just to reduce the mechanical shear stress on the vessel. Or what about severe preeclampsia? The drug of choice suddenly pivots to IV magnesium to stop seizures. The specific emergency state tells you exactly what to do. Now, amidst all these incredibly nuanced guidelines, there is one universal, absolutely non-negotiable warning from the authors. Never, ever use short-acting formulations like sublingual nifedipine. These drugs cause precipitous, totally unpredictable, and extremely dangerous drops in blood pressure. They are the exact things that can instantly trigger those ischemic strokes and heart attacks. Honestly, it's an outdated practice that just causes profound iatrogenic harm.
Which brings us to the final takeaway. High blood pressure is incredibly common, right? It affects roughly 1 in 4 adults. And while these extreme crises are thankfully rare, when they do happen, the stakes literally could not be higher. Knowing when to act fast with an IV and when to hold back and act slow with a pill, well, that's the difference between saving a life and inadvertently causing harm. So, is your clinical playbook up to date? Thanks for joining me for this explainer, and keep learning.